If someone wants to use an LLM at 2 a.m. when they are dealing with a craving and they want to avoid using or relapsing, then I think if it can be done safely, that's a great use case. But somebody who is starting to consult with it every single time they're about to have an interaction with another human being, or running all of their texts through an LLM to make sure that going to be received well by the other person, there comes a point where there's a risk of an over-engagement that I think we have to be careful about as well.
Hello, and welcome to Season 2 of Beyond the Couch, AI in Psychology. I'm your host, Dr. Ernest Wayde. Now, as always, before we get started, I want to thank the organizations that make this podcast possible. This episode is sponsored by the American Board of Professional Psychology, the National Register of Health Service Psychologists, and my consulting firm, Wayde AI. Their support helps us create thoughtful, psychology-focused conversations about how AI is shaping our field. I've been looking forward to this conversation because I get to welcome a psychologist whose work has helped shape how evidence-based mental health care is actually implemented, adapted, and sustained in real-world settings, and how technology can extend that impact. Dr. Shannon Wiltsey Stirman is a professor of Psychiatry and Behavioral Sciences at Stanford. She is the co-director of the Center for Responsible and Effective AI Technology Enhancement for PTSD Treatment, also known as CREATE. Her work focuses on implementation science and evidence-based treatments for PTSD and depression, particularly how interventions are trained, adapted, and sustained in real-world settings, as well as how technology can expand access to care. More recently, her work has focused on how large language models can support evidence-based mental health interventions. She's held leadership roles with the American Psychological Association and was awarded the Association for Behavioral and Cognitive Therapy's Mid-Career Innovator Award in 2018. Wow. Shannon, welcome to the show.
Thank you. Thanks for having me.
I'm really excited to have you here. But before we get started, I always like to start by asking, can you tell us a little bit about yourself, your work, and the journey that led you to AI, including the experiences that might have shaped your perspective?
Yeah. So I got my PhD in 2005 and really had been interested in implementation and basically when something's effective, how do we make sure that it gets to the people who need it? You know, it gets into the hands of the therapists who can provide it, and it gets to the individuals who really are looking for care and looking for something effective. So my work for many, many years focused on, questions around how do we support providers and train therapists, when there's a new treatment that it's effective. What do we do to help agencies make sure that they can train their staff and get it implemented so that it can reach more people? And that was really the question that kept me up at night, is like, how do we make sure that people get treatments that can really help them?
Uh-huh.
And so that's just been a lot of where my work has focused. And we've always had an issue of scaling, because what we know is that, just reading a manual or going to a workshop doesn't get therapists to the point where they can really comfortably and skillfully provide a new intervention. Think about all the years of supervision and training that we got. So when something new comes along, especially if it is a bit of a paradigm shift, we need more than just 2 days in a workshop. So the challenge is that when you have things like consultation and, ways to troubleshoot and talk to somebody who knows the treatment well, that's just very, very difficult to scale. So AI started to look really promising, especially with things like opportunities to practice with simulated patients before you ever even get into a room with a patient, try something new, especially if you're dealing with something that's high risk or complex. So that seemed like a very great use case. And I have been working with folks at Stanford, including our associate director, Betsy Stade, and Johannes Eggstad, and some other folks at Stanford who have really been thinking a lot about this technology. And so we started to test out and see what it could do, not to replace therapy, but to sort of provide different kinds of support for therapists and for organizations that are working to implement different treatments. So that's really kind of how I came to this area.
Yeah, I love that. I love that use case, especially having it as a practice tool, because I really agree what you're saying is going to a workshop is not enough to really get you feel comfortable. So having the opportunity to practice with AI sounds like a really great idea. When we talk about AI supporting therapy, what are some of the most realistic things these tools can actually do and do well today?
Yeah, it's changing all the time. I think that one of the things that people have heard the most about is, scribing and helping with things like clinical notes. And there's been a lot of interest in that because it can reduce some of the burden, help therapists spend less time on paperwork and more time supporting their clients and hopefully reduce burnout. I know there's some research coming out that's looking at those questions. But there are additional opportunities, I think, that can come from that. If you're already, have an AI scribe kind of listening to a session, we can add in things like opportunities for reflection. The client said something like this a couple of times, and that wasn't something you picked up on. I wonder if that was an intentional choice. Or working on a particular cognitive behavioral strategy. I noticed you didn't follow up on how they would practice between sessions. Do you want some coaching on how to do that? So I think that there could be opportunities to sort of provide support in those ways, or even, sort of a consult on demand where, people can ask, what are different ways to deal with this particular issue, when I'm providing, this therapy. So I do think that there are some opportunities there. And the idea would be not to do it in a way that, sort of you hear a lot about de-skilling these days. And I think we have an opportunity to actually go in the other direction. Writing clinical notes can be an opportunity to reflect. It can also just be something that people get done or, check things off on a template or. And so if we can find ways to sort of integrate it into the workflow and give therapists some feedback and food for thought in a way that works for them. So I think these things have to be designed for supporting therapists. They have to be designed, with a lot of input from therapists about how they'd want to receive feedback, where in the workflow, what would be most helpful, what they're interested in, what they're not. But I do think there are some real opportunities there.
Yeah, I love that concept of turning something that most therapists don't like, which is the note writing, the administrative task, into something that's actually very helpful and reflective. I love that opportunity that AI can bring there. Do you have any examples of how you've seen it meaningfully implemented in that evidence-based care? Because I know you're really big into evidence-based care.
Yeah. So one thing that has come up, written exposure therapy is a brief trauma therapy. It's about half the length, a little less than some of the other trauma-focused therapies. And there's been a lot of interest in that in settings where people don't see people over the long term. For example, primary care settings. It's been piloted in some addiction treatment settings where, there might be 28 or 30 days. And a lot of other places where, there's a lot of pressure to get, to see people and kind of help people get through episodes of care more rapidly. And plus, a lot of people don't come to therapy for more than 5 to 8 sessions.
Yeah.
So written exposure therapy has been a place where there's a lot of demand, and there aren't that many people who know how to do it because it was developed and tested in the past, decade or so. So we've been developing a tool that simulates patients that people can try the written exposure therapy intervention and walk through the sessions, get feedback, go back and try things again. If something didn't seem to go well, try things out with more challenging scenarios. So that's one use case. And I think there are some other really good use cases for things like suicide prevention, helping people develop a safety plan, especially situations where people are dealing with high risk and it's a little intimidating to walk into a session and try something you haven't done before.
Yeah.
With a client that maybe has some complexities or might not respond super favorably, right? So people can kind of try out their feared worst case scenarios and really figure out how to handle it and get feedback through simulation so they don't have to do it for the first time in real life. And I think that's been appealing to some of the therapists we've been trying this out with and getting input from. So I think that's one really useful opportunity. And then following from that, it's the same tool with some different capabilities could continue to provide, quick consults when people need it or feedback on how the session went when they do it in real life with someone.
Yeah.
So those are some of the first use cases we're looking at. And then we're already looking at expanding it to some other treatments as well.
That's really awesome. I love that practical use. Now, I know there's a lot of people using it. From your experience, what are some of the things that people are either overestimating or getting wrong about these tools right now?
Well, I think that there's a lot of concern about using it to replace therapy or whether people are using it for therapy. And my colleagues at Stanford and I looking at some of these questions, big survey of about over 1,500 people, kind of nationally representative, as nationally representative as we could make it. It looked like almost a quarter of participants had used it in for mental health purposes in the past few months. So there have been other studies as well. So we're talking about millions of people who actually are already using it. And on the one hand, I think we can't bury our head in the sand. People are voting with their feet. They're going direct to, these general purpose large language models and using it for things they think they need it for. So I think we can't ignore that. Many people, though, were using it as a supplement to therapy, not to replace therapy, although some were using it to replace therapy. But I think that one thing that we need to be really thoughtful about is there are a lot of things that they still can't do that therapists do. Now, that could change over time in different ways, but they don't perform, diagnoses. Now, there are some that are being trained to do more diagnostic interviewing. But at this point, they're not doing an assessment the way a therapist would. They don't case conceptualize. Many people have heard about the context windows and how the memory starts to degrade over time. And so they're not going to be able to case conceptualize. They're not going to be able to treat people in the same way that the therapist would adjust the treatment plan when something changes, when there has been improvement. So there are a lot of capabilities that really haven't been, certainly not built into the general purpose ones. There are some specialized tools that are being built specifically for therapy. And those, I think, are grappling with these issues. But, right now, those are some of the things that these sort of general purpose chatbots and maybe to some extent, even the specialty ones haven't really mastered yet. We do really have to be careful about scenarios where it's appropriate for people to be using them. And, certainly we've heard things about safety. My sense is that the companies are working on this. And when issues are exposed, that they're trying to address them. So, the general purpose ones are getting better and better. But whether they're following the best practices, one thing they're still not doing are the types of warm handoffs that we might do as therapists. When we need to escalate care. So I think there's a lot of room for improvement there. And there has been some overestimation of how hard a problem it would be to really successfully use these to replace therapy. Yeah. I mean, there have been some clinical trials. The Therabot trials showed that. Yeah. I think they've built that really carefully and thoughtfully, and they're doing a lot of good research to try to understand what it can and can't do. But we're still a little early. That was people with elevated symptoms, not necessarily people that got a full diagnostic workup. So I think we still have a ways to go.
Yeah, I really appreciate what you're saying in terms of people are voting with their feet. They're using it, even the ones that aren't formatted for this in terms of large language models, which are not meant for mental health treatment, but people are using them. I think there was even a study last year that showed that ChatGPT could be thought of one of the greatest healthcare providers, mental health providers, because so many people were using it. Right? I think also what you're talking about, there's still some distinction between what psychologists can do and what these chatbots can do. Where do you think the boundaries should be between what people use AI for and what they really should be using a human therapist for?
Yeah, I think it's a really good question. And it's something we've been grappling with. We had a webinar series recently on, can it be done and should it be done around the question of AI therapy? And what are the bounds? And I think, some of the things that are really important to think about is, psychologists and therapists are trained when we're working on that we have a theory, right? We have theories that and frameworks behind what we do and research, hopefully, right? And so we're conceptualizing and planning in a way that addressing specific problems, like, especially I think when we're dealing with diagnoses, this is certainly where the FDA has fallen. If you're trying to treat a diagnosis, this is not something a chatbot should do without regulation. And I think that sounds a reasonable first place to go, for self-exploration, et cetera. We hear about people who are using journaling and then, there's some sort of interactive reflection that an LLM would do. And people have found that helpful. And, I don't know. I think we really need research to tell us, but I think certainly places where we're dealing with high risk, places where we're dealing with, diagnosable mental health conditions, I think we really need more research before we would start entrusting, this kind of thing to an LLM. And they, they might get to a point where they can be helpful as an adjunct for therapy or even in some cases, to replace some things that therapists do. But we don't have the data to suggest that they do right now. And we have some evidence that they maybe wouldn't be successful at this point, or some of them. Certainly not the general purpose ones. And so I think, number one, we just need more research. But I do think in terms of where the bounds are for therapy, advice giving happens everywhere.
Mm-hmm.
People reach out for support to a lot of people in their lives. And we certainly don't require people to have licenses to do that. But I think when you're systematically treating something, from a theory or a framework that would require a lot of professional training,
Mm-hmm.
then, we'd really need research to demonstrate that these chatbots can do that kind of thing safely and effectively before I think we should, hand that kind of work off.
Yeah.
And same with diagnosis and assessment. That's not something that they've demonstrated an ability to do in the mental health domain at this point.
Mm-hmm.
And so I think I think that's another place where we'd need to see good research before we would think that that's something that they could be doing.
Mm-hmm. Yeah, I think that's really important is to try to define some of these boundaries and communicate them with the general public in terms of what might be safe use and what becomes risky and dangerous use of AI. Let's flip to the other side, right? Because we also have therapists and psychologists using these tools as well. What should the boundaries be for therapists and psychologists using AI versus where they might want to be very careful about using AI?
Yeah. Well, I think one thing is it's really important to be aware of and understand that sort of the terms of use and the privacy around anything that you're using.
Yeah.
And, actually one thing that some of these large language models are quite good at is summarizing. And so, you can actually ask it to summarize all those terms of service and, user agreements and ask questions like, where will the data be shared? And it can help you, can help read through all the legalese, So I think definitely being very careful about, the privacy issues. There are potentially really nice uses. One of the things that our group is looking at is using it to support people doing, practicing between sessions. So if they're doing a, cognitive behavioral therapy practice or something, that large language models might actually be able to provide some support around that. And, if there's a dashboard, the therapist could be looking at, okay, great. They did a couple of worksheets. They did
Mm-hmm.
these exposures this week. And, here's a little summary of how it went. So I know when they come in right away what we need to be working on.
Mm-hmm.
But I think it's very much not something, I don't think it's something that could be fully outsourced. So I think the therapist would need to be looking in, making sure that these things are happening safely, kind of reviewing there should be safety testing before something like this is rolled out, but still you'd want to review and make sure that what the chatbot is doing in those cases is consistent with, with the therapy model that you're using and safe, et cetera. But I think that, those can be great. Those types of things can be great opportunities. You just wouldn't want to give it too much autonomy. You'd want to be checking in pretty carefully. So I think that those are a couple of things to be careful about. I think also being careful about how the fit is going to be for the individual that you're working with before you would recommend something. Looking at whether or not the tool has been, tested or designed in such a way that would reduce bias and that it would be sort of culturally congruent with what your client would need. Being very careful about the types of recommendations that it would be making, to make sure there's no misinformation. A lot of the general purpose LLMs, are trained on the whole internet, right? And so especially early on, what you would get back is a lot of therapy speak, but you could get misinformation and you could get, inappropriate advice. And so, I think really checking in to be sure that what it would be providing is sort of consistent with what your individual client would need.
Yeah.
And also thinking about things like the potential for dependence. I mean, if someone wants to use an LLM at 2 a.m. when they are dealing with a craving and they want to, avoid using or relapsing, then I think if it can be done safely, that's a great use case. But somebody who is starting to consult with it every single time they're about to have an interaction with another, human being, or running all of their texts through an LLM to make sure that going to be received well by the other person. There comes a point where there's a risk of overuse and overengagement that I think we have to be careful about as well.
I love those examples. I think really making sure that because it's available doesn't mean that it's something that you should always be using. So that's really important. Now, so I want to ask you a little bit from the organizational level in terms of the implementation, adaptation, and use, because a lot of hospitals and healthcare systems are implementing AI applications and tools. What are the things that they really need to be careful to make sure that they're doing in terms of responsible implementation? What does that actually require from an organizational level?
Well, I think one thing is that there needs to be a lot of transparency. Again, understanding how the data will be used, making sure, obviously, organizations are going to be looking at things like HIPAA compliance, et cetera, hopefully, but, in addition, being very transparent with users, if we're going to use a scribe, or ambient recording, how will the recording be saved? Will the transcript be saved? For how long? Could it be subpoenaed? So I mean, there are a lot of things that that clients and patients would want to know that I think we need to be prepared to have answers for.
Hmm.
I think as well, we need to be really thinking about how to support therapists and staff in using it responsibly, and using it in ways that can enhance the treatment and support the client's needs. So, for example, if you have a tool like this, and let's say you've got a tool that would allow your client to do some check-ins between session with an LLM, or get some support between sessions or something like that. We need to train people to use, whatever dashboard is sort of relaying that information to the therapist, and help them figure out ways to really use it to enhance therapy. So, one thing that therapists might really appreciate is, instead of, 20 minutes of the session being kind of catching up on the last week or two, or having a brief summary, so that we can jump into like what really, where the work is really going to happen.
Yeah.
And so, I think that there really are opportunities, but therapists need to sort of be conversant and understand how they can be using them. And also, really, there's quite a range of, consumer perceptions and attitudes about AI that we need to be thoughtful about. Some people don't want anything to do with it.
Yeah.
Other people think it's great, and they've already embraced it. They'll come in and show you their LLM therapist that they've built for themselves. And so, just understanding kind of how to work confidently with that whole range of attitudes, and adjusting, as you go with people, depending on their comfort level and where they are.
Yeah, I think to that point, I think one of the most important things is actually for the therapist to increase their AI literacy around what the tools are, how they're being used, and all of that information. You've mentioned Create a few times. Can you tell us a little bit about what that is and how that is helping to educate and provide resources?
Yeah, sure. Creates a center. It's funded by the National Institute of Mental Health. Our goal is really to study and use AI to support access and implementation to effective therapies. So we have a few different projects that we're doing, that we're building products and testing them, and they're private. Everything stays, all the data stays within the research team. We're not selling it. We're not, so we are trying to sort of build tools that would allow us to study it in ways that you can't necessarily with industry, because a lot of them are a bit of a black box. Some are sharing their data, many are not.
Yeah.
And so we're trying to use them to understand how to build LLMs that can do some of these things that might actually help advance and improve the quality of therapy. We're also providing support for researchers. We provide, we do webinars and trainings and things. Occasionally, we do monthly webinars. Some of them are trainings for therapists. Like, we'll have one around using AI tools and, ethics around that. So it really is intended to be a resource for, both researchers and for practitioners and sort of the community, as we try to better understand how LLMs can help, and ways that maybe we need to be learning about and mitigating and improving. We're about to launch a study where we are going to just try to look at naturalistic use of LLMs, so we can better understand, because we have anecdotes that it really helps some people and it really harms some people, but we just don't really know. General use, if you give it to 1,000 people, how are people using it? Who's benefiting? Who's not? What are they doing that's effective? What are they doing that's not effective? And what's actually harmful? So that we can actually start, providing information about these things. And then also we're studying how these tools can be used to support therapists and train therapists. We'll be launching studies with things that we're building right now. So it's been really fun. It's a great opportunity to think more about these things and to have time to ask some of these questions. And we've got a lot of great people who are working, great collaborators who are working on questions both about the LLMs themselves and the way that they work, and how to tap into mechanisms of change in therapy, as well as, questions about how do we build one of these tools? What are user preferences? And then how effective are they?
Yeah, I love that. I love the accumulation of knowledge, right? And really trying to learn more about this new AI technology and the impact that it's having on both the clinicians as well as the patients that we're working with. I think that's really awesome. I want to be respectful of your time and just ask, how do people get a hold of you if they have additional questions or want to follow up with the conversation with you? What's a good way of reaching you?
Yeah, there are a few different ways. You can email me at Stanford. You can go to the Create webpage. It's create.stanford.edu. We've got a contact form. for everything, if you want to be a user experience tester, if you have questions, if you want to collaborate, you can go there and fill out the form, and that will get to me and our team. Those are probably the best two ways. I also have a LinkedIn profiles and webpage at Stanford that's called the Fast Lab at Stanford. So lots of different ways, and I would love to hear from people.
Awesome. Shannon, thank you so much for being on the show. Really appreciate it.
Thank you. Thanks for having me.
Awesome. And before I let you go, I always like to ask our experts, what's a tip or a last recommendation that you can leave us with?
I think in this area, I would say if you're a mental health professional or a researcher, get familiar with sort of the latest tools that are out there, and don't be afraid to try them out. A lot of times, when we're doing research, it's taking a while to actually get the research out. So there are a lot of preprints that I think people can be looking at, but I do think scrutinizing the research, understanding how fast these tools are moving, and something that you heard about 2 years ago probably isn't really the case. So just really staying on top of this area because it's changing really fast.
Yeah, I completely agree with that. I think it's really important to stay informed because it's moving so rapidly. Things are changing so quickly that it's really important to stay informed and try to stay up to date. So I really appreciate that. All right. Well, thank you again for coming on the show. It's been a pleasure having you.
Yeah, thanks so much. I enjoyed it.
Okay. And if you've enjoyed the show, please subscribe and leave us a review. Feedback is a gift, and we love gifts. We hope you'll join us again next time.